Good morning, all. How are you all? How's the last minute, the neck of the moment preparation treating you all? Good, bad? Okay. So it's 6 a.m. Let's formally start the class. Okay. So what I have planned for your last 6 a.m. class in psychiatry is that I am not going to go back into the usually discussed certain things, the basics of psychiatry or the common mental disorders or the, very commonly repeated certain topics. The thing is that we have discussed that extensively enough. But in our recent papers, like the past 2-3 years of INICET, and in the past 2 years of NEET-PG, we are getting a few unexpected questions in psychiatry. That is, all the faculties of psychiatry, including me, even the other national faculties, are not touching these topics extensively because they considered it all little, it is not needed for NEET-PG. That was what was considered. But for the past 2 years, we've been getting at least one question from these areas. So we cannot predict all questions, but still, since it is a common pattern, I am going to discuss a few difficult areas so that last minute, if you get a question, you can at least eliminate the option and choose the better answer. One. Another thing is that they have also started asking questions, image-based questions in psychiatry, which was never the usual thing, because in psychiatry, the questions are supposed to be a little easier and easily answerable. And psychiatry is kind of a text-based subject, so they never asked image-based subjects in a very detailed manner. But in the past few, the INICETs, because all of them are the same board, right? So these people have started asking image-based questions in psychiatry also. So what I'm going to, take you through is uh, a series of questions and a series of images, depending upon which our discussion will be for the next 1 hour. And also we will have certain, elements of how to handle this pressure. I don't know, somebody, I think S has sent that pressure cooker emoji. So how to handle this pressure cooker thing and how to be supportive of each other and how to get good marks in NEET-PG without all these pressure. Okay, right. So, you all can see the screen, right? So this question is a 19-year-old 19-year-old female with a diagnosis of bipolar depression. Okay, so for bipolar depression, we use a drug called as lamotrigine. Okay, and the psychiatrist decides to add another mood stabilizer for maintenance and chooses sodium valproate. Should there be any changes in the dosing of lamotrigine now? That is a question. Okay, so why I have given this is because they have been asking a lot of questions on bipolar affective disorder, be it the epidemiology, be it a bipolar affective disorder with pregnancy, and a lot of questions on mood stabilizers. The commonly asked questions on mood stabilizers are lithium, sodium valproate, and carbamazepine. So can you imagine? A lot of questions have been asked in this area, right? So it is only natural that the next question can also be on lamotrigine, which is one of the medicines. It is actually an anti-epileptic agent and it has been used for bipolar depression. Now, this also has a lot of interactions with these medications, other mood stabilizers. So this is one of a key area in psychiatry which can be expected in this exam or the next few exams. So this time we will also read this. Okay, so what are the options? So what have they told? The patient is on 50 milligram of lamotrigine. Okay, now again the doctor is adding sodium valproate. Now what should happen to the dosage of this lamotrigine because of sodium valproate? That is the question. Okay, the concept behind this is the drug interaction of lamotrigine with sodium valproate. Okay, that is the concept. Okay, so Yeah. So the thing is, they have asked if the same dose should be maintained. They've asked if the dose should be half to 25 milligram, dose should be doubled, or it should be given together. Yes, somebody has answered also. Okay, so what is the concept that we need to know is that sodium valproate is an enzyme inhibitor. Okay, so when it inhibits the metabolism of lamotrigine, what happens? The lamotrigine blood levels go up, right? Whereas carbamazepine is an enzyme inducer. So what happens? It induces the metabolism of lamotrigine, and hence lamotrigine blood levels go down. So from this question, you should know that when we give lamotrigine along with sodium valproate, we have to, here, since it is going up, we have to reduce to half. Whereas in carbamazepine, we have to double the dosage. Okay. So for carbamazepine, we have to double the dosage of lamotrigine, and for sodium valproate, we have to reduce to half. So the question's answer is yes, the dose should be half, that is 25 milligrams. This was not a previously asked question, but this is kind of an expected question because the trend is going in that way. So you should know it, right? Next one. Right. Next one. Which of the following mood stabilizers caused hepatitis and hyperammonemia? This was the question asked in the recent INI-CETs. Right? And yes, good. So the answer is sodium valproate. So you should know that sodium valproate has a lot of adverse effects, and it also like hair fall, pedal edema, hepatitis, hyperammonemia. All of these are hirsutism. All of these are side effects of sodium valproate. So that is important. So can you see why I have told you this lamotrigine? Because see, in the option there is lamotrigine, in the option there is carbamazepine, the option there is topiramate. So these questions can be expected in the future, right? Which of the following are included in Korsakoff psychosis? This was question in the I think May INICET 2024. Okay, so they had given ophthalmoplegia, psychosis, amnesia, and confabulation. So you know everything related to alcohol is always important, and every year they're asking at least one, even two questions from alcohol, and sometimes it is integrated with other subjects, but pure psychiatry itself they are asking one or two questions. Okay, so let's just look into this. What is Wernicke's and Korsakoff? So for Wernicke's, you all know what is the mnemonic? Goa. A person goes to Goa, drinks a lot. It's an acute condition. Wernicke's is acute condition causing Goa symptoms. Goa is global confusion, ophthalmoplegia, and ataxia. Okay, this is about Wernicke's, right? What about Korsakoff? So Korsakoff is kind of a chronic condition. After Wernicke's, it progresses to Korsakoff. Korsakoff itself is called as Korsakoff psychosis. So psychosis should be present, right? Too. And it causes lots of retrograde, it causes amnesia, mostly anterograde. What is anterograde amnesia? You have to remember Gajini movie. That is how you can remember anterograde amnesia. Whatever is happening after it will not be formed as long-term memories. And it also causes, since there is a lot of amnesia, the patient tries to fill gaps in his memory with certain stories or lies. That is called as confabulation. So the answer is 2, 3, and 4, which is B. So congratulations to all who answered. Right. All of the following side effects are seen with carbamazepine than oxcarbazepine, except. See, again, this was supposed to be coming with the first question also. Again, see here, there also sodium valproate and carbamazepine has been asked as a question. So, how many of you can answer this? This is kind of an important and frequently asked question. Good. So, for carbamazepine, everything is a side effect. Okay, carbamazepine is notorious for its side effect. Good Hari Prasad, good Ramya, all of you all. So what is happening is oxcarbazepine was a substitute for carbamazepine in order to reduce its adverse effects. But in oxcarbazepine, there is one adverse effect which is increased more than carbamazepine, and that is hyponatremia. So good, Nandhini, good. Right. Next, a patient with depression symptoms was prescribed amitriptyline. Again, very commonly asked question, and almost it has been repeating every other year. Since they didn't ask last year, they did ask this question last year, but still you should know the symptoms of, what is this a question of? TCA toxicity. So what happens in TCA toxicity? Yes, so there is symptoms of CVS where there is hypotension, right? And all of that, and increased pulse rate, increased heart rate, right? And then there is confusion, and there is anticholinergic effect. Anticholinergic effect causes what? Pupillary dilation, hyperthermia. So the answer is hypothermia, because they have asked all except. And it also causes arrhythmias, and it also causes QT prolongation. When QT prolongation is more than 100 millisecond, what should you give? You should give them sodium bicarbonate infusion and then dialysis. This is how we can treat a case of TCA toxicity. Now, of course, you have to withhold the drug as well. This is a previously asked question. Great. Now we are going to discuss some of the image-based questions. So the thing in image-based questions are very easy, but sometimes the image might be difficult for you because you are not exposed to a lot of things used in psychiatry. So I'm just going to give you a very short and broad interpretation. Okay, so this thing with an anode and cathode, this is transcranial. Of course, this is a transcranial direct current. So you're directly placing the anode and cathode onto the scalp. So it is a transcranial direct current stimulation. Machine is a stimulator. So it is called as TCDS. Transcranial direct current stimulation. Okay, good. So what is this? This is something everybody knows. Commonly used in psychiatry. ECT, good, Nandhini. So this is an electroconvulsive therapy. Now, few questions on ECT. In ECT, as of now, with Mental Health Care Act of 2017, direct ECT and modified ECT. Which one is preferred and which one is prohibited, please? So is direct ECT preferred now? Yes, no, quick? Good, good. So modified is only given, direct is prohibited. A child less than 18 years of age, can we give ECT or not? Yes, no? Good, Rohita. No, it is prohibited in children. If you have to give it, you have to get the permission from the board. Okay. And ECT is indicated for what of these conditions? For catatonia, for depression with, so is not OCD. Suicidal tendency. See, ECT you can use for a lot of things, but you have to know the important indications, which is catatonia, which is depression with suicidal tendency. If they are coming with depression with suicide, you have to write it as ECT. Yes, good, Surya. Okay, so after that, all the treatment resistant cases, treatment resistant schizophrenia, treatment resistant depression, treatment resistant mania, BPAD, treatment resistant OCD, also you can try it, but no, the important indications are these. Okay, good. So just an integrating question for ECT, which is the commonly used anesthetic agent. You have to read it with anesthesia thing. Okay, so look into which is the currently used anesthetic agent. Methotrexate. Okay, good. So they have not changed in that options. Good. Practically, we use different things, but for your MCQ point of view, what is the drug of choice for ECT anesthesia? Go to your anesthesia book and read it again. Okay. Right. What is this machine? This machine is a good, repetitive transcranial magnetic stimulation. This is called RTMS. Where is RTMS used? For treatment resistant depression. This you can use for OCD, Nandhini. This we can use for OCD and in treatment resistant OCD also. Okay, so this is mostly, it gives a very subtle magnetic field. It is like an MRI machine. In MRI machine, you use the magnetic field to generate images. In this, you use the magnetic field to stimulate certain areas of your brain so that it gets activated and your treatment resistant depression gets better. Okay, that is what you have to know with RTMS. Okay, and it is a non-invasive procedure. All of these are non-invasive procedures. Transcranial direct stimulation, RTMS, ECT is also non-invasive procedure. Invasive procedures, if they ask deep brain stimulation, using a neurosurgeon, you have to implant certain electrodes into your brain. So that will be a invasive procedure. Okay. Right. So what is this a picture of? Yes, that. Yes, Satya. DBS is deep brain stimulation used for Parkinson's mainly. Okay. Right. What this image is? Bell and pad method of treatment for nocturnal. Yes, good Prasanna. Nocturnal enuresis. Good Satya. So this is for nocturnal enuresis. We use a bell and pad method. Now this bell and pad method comes under what school of psychology? What is the principle used? Reward and conditioning, right? Reward and conditioning is a school of behavioral modification. So this is the first method. This was also previously asked in INI-CET for bell and pad conditioning. Okay, so this is also what to say. This is the first thing that you can use for nocturnal enuresis child after evaluating for any organic causes, and then you can go into other methods like certain drugs. Okay, desmopressin is one of the drugs that can be used, but the first thing is bell and pad method. Right. What is this image indicative of? This is one of the side effects of typical antipsychotic. So this is a case of oculogyric crisis. So one eyeball alone rolling upwards and standing there. Yes. So this is a subtype of dystonia and it is acute in nature and it occurs as a side effect of antipsychotics, especially good guesses. Benzhexol and promethazine is the treatment. Typical more than atypical. Okay, so tell me some more side effects of antipsychotics. Dystonia is one. Another side effect, few side effects, let's discuss. And yes, it is an acute condition, so you have to treat it with injection promethazine. Tardive dyskinesia, good. Akathisia, good. Promethazine or benzhexol. Right. So, other than dystonia, you can have akathisia. For akathisia, what can you give? You can give propranolol or low dose benzodiazepine. Okay. Parkinson-like symptoms, good. Oh, you gave akathisia. Then you told me about tardive dyskinesia. Tardive dyskinesia is more of a chronic condition. In that, you stop the antipsychotic and switch to clozapine, right? Because clozapine does not produce tardive dyskinesia. So you switch to clozapine and then you give them tetrabenazine, a drug called as tetrabenazine, which can be given for tardive dyskinesia. Then what else? Did you say drug-induced Parkinson's-like symptoms? So Parkinson's-like symptoms like resting tremors, tremors, rigidity, etc. Parkinson's, again, you have to withhold the drug. Change, you can give trihexyphenidyl or Benzexol, and then you have to withhold the drug, change it into an atypical antipsychotic, which does not cause so much of Parkinson's-like symptoms, right? And if necessary, you can again switch to clozapine. So what can we do in these conditions? Something you should know. Okay. Now, next question. What is this? Image based. If they give this image, what will you think of? What is this a condition of? Good, good. So it is catatonia. Right. So it is catatonia. So you should know all of the terms associated with catatonia. So if they, think about asking. So in what will be there? There is waxy flexibility. There is abnormal posturing. There is mannerisms. Right. Good prognosis. Yes, catatonic schizophrenia has a good prognosis. So since catatonia is such a dramatic condition, it can be associated with schizophrenia or bipolar, and it also has a good prognosis. What is the treatment? What is the injection that you would give? Anybody? Good, Archana. So you give IV lorazepam. When you give IV lorazepam, it gets better. Okay. After that, you can give ECT. Okay. Okay. So just because we discussed catatonia, just the symptoms of schizophrenia, according to DSM-5, there are 5 criteria, right? So what are these 5? Delusion, hallucination, abnormal behavior, or catatonia, right? Right. Negative symptoms, abnormal or disorganized speech. Okay, so from these 3, you should have at least 1, and totally you should have 2, of which 1 should be from here. So it can be both from first 3 or 1 from first 3 and 1 from 4 and 5. So this is how you can diagnose schizophrenia. Okay, for schizophrenia, you will diagnose it and you will give them treatment for antipsychotics. So some certain antipsychotics, typical antipsychotics, haloperidol, chlorpromazine, atypical antipsychotics, olanzapine, risperidone, aripiprazole, all of these are atypical antipsychotics. The atypical antipsychotic, the trademark thing is clozapine. Clozapine is used for treatment-resistant schizophrenia. There we use a criteria called as modified Keynes criteria. And if 2 antipsychotics given for adequate duration does not reduce the symptoms of schizophrenia, we use clozapine. Clozapine has a lot of adverse effects. Some minor adverse effects are sialorrhea, excessive salivation, sedation, weight gain, all of that. Serious adverse effects, myocarditis, leukocytosis, agranulocytosis, all of that can happen. Okay, so this is just to brush up. This is very common. Yes, good, Prasanna. Okay, now what is this? It is almost there in the picture. Russell sign. Russell sign seen in Mugarodikta. Yes. Russell sign seen in what condition? Yes, good. So it is seen in bulimia nervosa. So eating disorders, again, frequently asked question. Last time they had asked Hoff criterion is used in what? So that was eating disorder. Bulimia nervosa, since they induce vomiting, right? Okay, so the knuckles get injured again and again by their incisors and causing erosion here. That is called as Russell sign. So Russell sign is very pathognomic of bulimia nervosa. In bulimia nervosa, the people will not lose weight. They will want to lose weight, but they will eat a lot and they will induce vomiting or use purgatives and laxatives to compensate for it. Right. Whereas in anorexia nervosa, they will lose weight. They will not gain weight at all. They will not eat at all. Even if they eat half an idli, they will try to vomit or they will do a compensatory activity. Okay. So in anorexia, sometimes you have to treat them in a ICU setup, basically because they have lots of electrolyte disturbances and all the nutritional statuses are gone down. So you have to treat them in the ICU setup. Okay. And one of the questions previously asked regarding anorexia was watching the patient for 20 minutes or 2 hours after each meal. Even in the ICU setup, you're giving all of these rice tube feeding, etc., etc., and the patient is not gaining weight. Then you have to observe the patient for 2 hours after every meal. Maybe they will, without your knowledge, they will go into the bathroom and they will induce vomiting. So that was one of the questions previously asked. So in anorexia and bulimia, you have to know certain. Okay. Then what else is there? Binge eating disorder is there, and food fads like restricted food intake disorders there. So go and brush it. Okay. So this was the question asked again in May 2024 INICET. And I have been telling you this is the only question that can be actually asked as an image-based question in psychiatry, and they have already asked it, so they might go for other questions. Again, they can give this image and ask you a different question also. So EEG in sleep, you should all know. What happens in awake state? We have alpha waves. What happens when we close our eyes? We have beta waves. What happens in REM? Again, REM is just closing our eyes and having almost like an awake state. So that also has beta waves. Okay. Non-REM, when you are going to sleep, it starts with theta waves and then goes into delta waves. So by non-REM stage 3, 4, you will have delta waves. And in stage 2 of sleep, you have two different things called as K complex and sleep spindle. You can see in the image, blue box, fourth blue box, sleep spindle and K complexes will be there. Okay, this is kind of important. And this REM is REM sleep EEG is almost like a sawtooth pattern. So sawtooth pattern is a commonly used word, commonly asked question. So you should know this word is also associated with it. Okay. Okay, now what is this? So recently again they have started asking certain psychotherapy, certain psychology oriented questions. So once they asked about transference, and then they asked about certain defense mechanisms, then they asked about a psychotherapy, supportive psychotherapy, where it can be used. Those kind of questions have been asked. So I have also included certain aspects of psychology. This is called as Maslow's hierarchy of needs. So what he said, for a person to live, first they have bottom triangle, bottom base of the triangle. Here their physiological needs should be met, like they should have food and water to drink. Then they should have safety. They should have a, right, if they are living on the roads, if they are living in a forest, they should have a house or hut in order to protect them from the climate, animals and other predatory things. And then they should have a connection, feeling of connection, right? So there comes love and affection. Then they should have certain esteem needs. They should be able to study, they should be able to improve in their career. So once your physiological needs are met, only you will think about your safety. Then only you will think about love and affection. Then only you will think about your self-esteem. When all of these are attained, when you attain a higher sense of consciousness or higher sense of peace, like certain successful people like Swami Vivekananda or other people who have actually realized their value in life, that is called as self-actualization. Okay. So Maslow was a psychologist who gave all of these. So you should remember Maslow's hierarchy of needs. You should remember this triangle. You should remember this word called as self-actualization. So if they ask, this kind of question, only these will be targeted. Okay. And they might even ask you order. So first physiology, first safety might be given, the safety physio, and then they will ask you to choose the first order. So always physiological needs. You need food in your plate. Only then you will think about a shelter. Only you have a good home, you will think about having somebody, family, love and affection. Only then you can go to school and study. Only then you can have a career. You will have a good self-esteem. After that, final is self-actualization. Right. Again, autism questions are again and again asked in some or the other way. Okay. So autism spectrum disorder, all of the following clinical features are seen except. Can any of you answer? D. Good SS. Yes. So abnormal cognition means abnormal intelligence. See, in autism, they have never commented about cognition. See, wait just a second. Sorry. Yeah. So this is the criteria for autism spectrum disorder in DSM-5. So if you see, there should be an impairment in social interaction and communication. So that is given by certain subsets. Okay. And then there should be abnormal repetitive behaviors. Only these are there. Even delay in speech is not there. Only these two are the criteria. Remaining is from early childhood and it should not be a normal thing. It should limit their regular activities. Okay. So abnormal cognition is not a part of autism. Again, autism related. Rett syndrome was asked. Rett syndrome is more commonly seen in females more than males. And what is the drug that they developed for Rett syndrome? Trofinetide. So in the last INI-CET, how this Rett syndrome question could have been incorporated was they asked a different drug. I think cannabidiol was asked and they had given various options. So cannabidiol is a newer anti-epileptic agent. Okay. And they had given a lot of syndromes. In that, Rett syndrome was there. So if you know for Rett syndrome, only trofinetide is a drug of choice, no other drug is available, then you can eliminate that option. One more option was eliminatable. So you would be able to answer better. That was actually a pharmacology question more than a psychiatric question. So what is this? If they give this image and ask you, what is this a case of? What will you say? Yes. Okay, since I'm a psychiatry faculty and we are discussing psychiatry, you will easily say this is trichotillomania. What if it is in the NEET-PG and you're confusing with certain dermatological conditions? Right. So you should be looking at it. See, what happens in trichotillomania? You pluck the hair. So always accessible part of scalp will be lost. So here you pluck your hair, right? So accessible hair will be lost and it will be a patch where there is no hair at all. In alopecia, it will not be in this kind of accessible areas alone. It will be there all over. Okay, good. Right. Exclamation sign. Okay, fine. Right. So what, another thing about trichotillomania, what spectrum of disorders it is a part of? Obsessive, compulsive and related disorders, right? What else has in obsessive compulsive and related disorders? Body dysmorphic, body focused, repetitive, good to BOH, remember the mnemonic, repetitive behaviors, OCD, olfactory, reference syndrome, hoarding disorder and hypochondriasis. Hypochondriasis this is all in ICD level. Okay, so this is the latest thing. Hypochondriasis is actually a fear of having a significant illness, which is part of illness anxiety in DSM-5 and OCRD in ICD. Okay, so why I have put this image is, this is an image of a cocaine drug user with a lot of skin lesions. So what happens in cocaine users? What is the type of hallucination seen? tactile hallucination, also called as formication, also called as Magnan syndrome. So this question, I don't know why they have asked so many times, but they have asked almost every year. Yeah, bugs under the skin sensation. So they will have a lot of skin lesion. So this you should know because they have been asking it again and again. So they can again ask it. Okay. A patient has repetitive thoughts and about contamination and compulsive hand washing. What is this a disorder of? Again, recently they've been asking such kind of questions also, which is from the mental status examination part. So what is this? Cognitive disorder. Why, Arun Kumar? This is a cognitive disorder. Yes. Yes. Good. So this is a thought disorder. So thought disorders have been classified into disorders of form of thought, disorders of thought content, disorders of thought possession, and one more, form content, disorders of flow or stream. Okay, so what is the disorder of thought content called as? Yes, good. So delusion. Under disorder of thought possession, you have OCD and disorders of thought alienation, that somebody is controlling my thought. In thought alienation, you have thought broadcasting, thought withdrawal, and thought insertion. Okay, this also comes under first rank symptoms of, no, passivity is first rank symptoms. So this also comes under first rank symptoms of schizophrenia. But as of now, thought alienation, only these three. Disorders of form of thought, disorder of thought stream, the thought stream, you have perseveration, you have thought block. Okay, you have increased rate of speech. Right. Okay. In disorders of the form of thought, you have derailment, you have loosening of association, you have neologisms. So all of this can be given and asked, what is it a disorder of? So this is such a simple question, but you should know all of this to answer this question. Okay. Okay. What if I had given this patient is having hallucinations? Okay, I'll say this patient is able to hear voices commenting about him, and same options are given. What will be the answer? Good. So it will be a perceptual disorder. Now, what if I had given this patient is having a lot of emotional disturbance and having suicidal thoughts about what is the purpose of living, then it is a mood disorder. Good, Prasanna. Now, what if I told this patient is having a lot of forgetfulness, not able to plan and execute actively? Good. Then it is a cognitive disorder. Cognitive disorders, only two. Neurocognitive disorders, only two major categories we have been discussing. One is delirium, which is acute in nature and has disorientation and confusion. Whereas the other is dementia, which has a lot of subtypes. Okay. Dementia drugs also they have been asking. So please brush it through. Okay. Now this one, we'll come back after some time. Okay, so you can take a screenshot of this particular thing, or even I'll send it to you later. So these are what you have to just revise at the end. Okay, this is like you have to just revise these things. Key points. It will take like 1 hour or something for you to revise this from our workbook and all our discussion, etc. And you will be able to get at least 3 questions or 4 questions out of the entire 5 to 6 questions of psychiatry in this NEET-PG. Okay. Right. So let's discuss that image, the drugs image. Okay. So we have already discussed this, and this is something I've also shared with you in your group. So if you just go through this, almost all basics of psychopharmacology is covered. So first generation typical antipsychotics have a D2 blocking property. Because of D2 blocking in the nigrostriatal pathway, you have EPS, which is a side effect. Because of its D2 blocking property, in tubero-infundibulار pathway, you have increased prolactin hyperprolactinemia. Because of D2 blocking in mesocortical pathway, you have worsening of negative symptoms in schizophrenia with typical antipsychotics. But the favorable effect which supersedes all of these side effects is the blocking of D2 in the mesolimbic pathway, which causes decrease in the positive symptoms. So what are certain atypical, certain typical antipsychotics or first generation antipsychotics? Haloperidol, chlorpromazine, thioridazine. Haloperidol has oral preparation, IM, IV preparation, and even depot or long-acting injections. Chlorpromazine, corneal lenticular deposits is one of the side effects, and it has a lot of anticholinergic effect. And it also causes hypotension, postural hypotension, and sedation. Thioridazine is not used nowadays because of its serious CVS adverse effects, prolonged QTC interval, and retinal pigmentation. So if they are going to go back into a very old type of question, they can ask corneal lenticular deposits side effect of chlorpromazine, retinal deposits or retinal pigmentation side effect of thioridazine. Next is second generation or atypical antipsychotics. In this, along with the D2 blocking property, there is also 5-HT2A blocking property and 5-HT1A agonism. Because of this, these drugs have lesser EPS. But the problem is these causes lots of increased metabolic adverse effects. Why metabolic adverse effects? Because of 5-HT2C blockade. This was also one question. So you should know metabolic adverse effects caused because of 5-HT2C blockade in the atypical antipsychotic. So you should know also some names: olanzapine, risperidone, aripiprazole, clozapine, etc. So clozapine, it has D4 more than D2 blocking property. It has the least EPS and maximum weight gain. It is anti-suicidal. It has anti-suicidal property. One more drug has anti-suicidal property. Can you remember anything? Not olanzapine, lithium. Okay, so anti-suicidal property is for two drugs, clozapine and lithium. Okay, and it is given for good SS, good all who said lithium. Okay, and you should also know the common adverse effects we just discussed. And one of the serious adverse effects is also seizure. Okay, seizure, agranulocytosis, and myocarditis. Newer antipsychotics, brexpiprazole, given for it is approved for agitation and dementia. Okay, cariprazine has D3 agonism, so has better cognitive improvement. And pimavanserin is given for Parkinson's disorders with psychosis. See, Parkinson's disorder is something where dopamine is low. Correct. For that, you will give levodopa, carbidopa, you substitute dopamine. Now, when dopamine is high, you get psychosis. For psychosis, you give D2 blockers, which is again going to cause you Parkinson's-like symptoms. Now, both Parkinson's-like symptoms are present and psychosis present. What will you give? You cannot give dopamine also. You cannot give dopamine blockers also. So, for that, there is one excellent drug called as pimavanserin. Okay. Okay. Now, coming to mood stabilizers, we already discussed some. So, for lithium was identified by John F. Cade. It has renal excretion. So, for lithium question, if they are giving with certain kidney-related symptoms, you have to think about lithium toxicity. Okay, it has anti-suicidal property. We just discussed. So, therapeutic range is 0.5 to 1.5. Mania, you have to maintain 1.1 to 1.5, and for maintenance, 0.6 to 1.2 milliequivalents per liter. If it goes for more than 1.5 milliequivalents per liter, you will start having toxicity symptoms. For toxicity monitoring, you have to have a lithium blood levels. You have to draw the sample 12 hours after the last dose of lithium given for 7 days. So if I'm going to start lithium for a patient today is Wednesday, next Wednesday, that's after 7 days, after taking the night dose, they have to take the sample in the morning. So night 8 o'clock, if they have taken the last dose, I have to take it at 12 hours after the last dose, after 7 days of drug injection. Okay. Okay, so what will happen? Adverse effects, tremors, polyuria. Tremors and polyuria are seen in normal lithium levels itself. So it is like an adverse effect. For example, you take certain drug, you get gastritis, right? So that kind of adverse effect is tremors and polyuria. It is not a toxicity symptom. Toxicity symptom will be when the therapeutic levels are exceeded. So even with 0.5 to 1.5 milliequivalents of lithium itself, you can get tremors and polyuria. This was in a way asked in a previous question during AIMS, JIPMER, that way it was asked. So you should know. In normal lithium intervals itself, you will get tremors and polyuria. Okay, toxicity symptoms for mild toxicity, that is less than 2, you will have vomiting, abdominal pain, ataxia, and nystagmus. More than 2 to 2.5, have persistent vomiting, increased deep tendon reflexes, seizure, and coma. And in severe, that is more than 2.5 milliequivalents, you have almost renal failure symptoms and death. Okay, so what you can do is dialysis, peritoneal dialysis. Okay, you should stop that hemodialysis, sorry. Stop lithium, hydrate, and do hemodialysis. Lithium is also known for its teratogenicity, but it has only 1:1000, causing extreme anomaly. Okay, whereas sodium valproate has a very high teratogenicity compared to lithium, and this should definitely be avoided. Right, and it is a treatment for acute mania, hyperammonemia, and neural tube side effects, hirsutism, and drug interactions are its adverse effects. Drug interaction, let's just see how much you've remembered. What is the drug interaction between lamotrigine and sodium valproate? If you're giving lamotrigine and sodium valproate, you should reduce the dose or increase the dose. Good. You should reduce it to half. Good. So carbamazepine, again, it can be given for acute mania. Nausea, vomiting, ataxia, auto-induction are the side effects. So auto-induction means carbamazepine, after some months, you have to increase the dosage of carbamazepine itself because it will induce its own metabolism. Okay. And it causes blood dysgeriasis, hepatitis, rashes, etc. Oxcarbazepine, all better, but hyponatremia incidence is high. And lamotrigine is given for bipolar depression. Okay. Now, antidepressants and anti-anxiety agents. SSRIs, you should know certain SSRIs, Sertraline, fluoxetine. Drug interaction, DI means drug interaction. Okay. Adverse effects of SSRIs. Gastritis-like symptoms, diarrhea or constipation because of serotonin activity. Right, it can cause vivid dreams, libido, decreased libido, anorgasmia, delayed ejaculation is important. Delayed ejaculation, you can give for premature ejaculation, you can give SSRI as a treatment because it causes delayed ejaculation. One drug that was developed for that particular indication is dapagliflozin. Okay, good. Okay. Now SNRI, venlafaxine, desvenlafaxine, all of these are milnacipranol, all are SNRIs. These can be given in elderly perimenopausal women. Remember, perimenopausal women, when they are having a lot of depressive symptoms, anxiety symptoms, usually SNRI is preferred because it will also address their neuropathic pain and their menopausal symptoms like hot flushes, all of that will be there. No, that also will be addressed by SNRI. If they're giving a question of a person in the 50s or 60s with some symptoms, if there's an SNRI, you can choose that. NDRI, bupropion. Okay, it has no sexual side effects, so it can be given in people who are not able to tolerate SSRI because of sexual side effects. Right? And it is contraindicated in head injury, seizure, and bulimia nervosa. SARI, serotonin antagonist. Trazodone and nefazodone are SARIs. MAO inhibitors, salicylic, rasagiline, cheese reaction caused by MAO inhibitors. It should be cheese reaction caused with SSRI or SNRI. It can be MAO inhibitors are very useful for melancholic depression. Okay, right. TCAs, you should know amitriptyline, nortriptyline, imipramine, and TCA toxicity we just discussed. BP, decreased chest pain, palpitations, altered sensorium, seizures, anticholinergic symptoms, metabolic acidosis, increased QRS, QT interval, AV blockade. Yeah, you have to give sodium bicarbonate as a treatment when there is severe symptoms, right? Next, in pregnancy, again, frequently asked area. So, antipsychotics, if you are planning pregnancy, you should avoid changing the antipsychotic unless otherwise it has a high teratogenic effect. Okay, and if you are giving some atypical antipsychotics, it might cause a lot of gestational diabetes. So you have to do oral glucose tolerance test, and sometimes neonatal withdrawal symptoms should also be kept in mind. Okay, so the better antipsychotic is quetiapine. Antidepressant, again, you should not discontinue. The problem is pregnancy is a stressful situation, and if you discontinue something that is already working for you, it is going to precipitate symptoms. Then you will have to give a higher dose of all of those drugs, which will be again detrimental to the baby. So it is better to maintain certain things if they are relatively safe. Okay, so do not discontinue, and if there is a moderate to severe depression, you can start an antidepressant. For mild depression in pregnancy or in the postpartum period, what is the treatment of choice? Anybody? Mild. What is the psychotherapy of choice? They ask the treatment of choice. You can say it is better word. No, cognitive behavior therapy, CBT. Okay, remember, CBT is the treatment of choice. So supportive or counseling, these are all not evidence-based, but CBT is evidence-based. It has good treatment response in mild depression symptoms. Okay, great. So the better thing is sertraline given pregnancy, and anyway, if you give SSRIs, other antidepressants, it can cause increased preeclampsia and it can cause persistent pulmonary hypertension in discontinuation syndrome in neonates. Okay, mood stabilizers, again, mood stabilizers are the highly notorious things to cause teratogenicity, right? So if you're planning a pregnancy and the patient is on a particular mood stabilizer, say it lithium, sodium valproate, or carbamazepine, all of that has some or the other adverse effects. So you try to switch it to an antipsychotic. Atypical antipsychotics have mood stabilizing action. So you get to switch it to an atypical antipsychotic like olanzapine or quetiapine, right? And if they are on lithium and they already got pregnant, you just adjust the dosage according to the blood levels, and you should monitor their lithium blood levels again in a serial way, right? You should not stop it because of the risk of postpartum depression, because bipolar affective disorder always has a postpartum risk. So generally pregnant women has a risk of postpartum depression. If they're already known case of bipolar, then they will have frank psychosis. Postpartum psychosis also can be common. It's very difficult to treat. So it is better to put them on a mood stabilizer before itself. So risk of toxicity of lithium is there after delivery. So you decrease the dosage because you have to monitor the lithium levels, and then you obviously will decrease. But after delivery, all your water content in the blood goes down. So there is a risk of toxicity, right? No sodium valproate at all. Mostly you avoid all antiepileptics. For lactation, what is the better antipsychotic? Olanzapine, quetiapine. If clozapine is there, you have to stop breastfeeding. Clozapine will cause serious effects in the kid, and it has a lot of relative infant dose in the lactation. So clozapine, you should stop breastfeeding at all. Antidepressant, sertraline, mirtazapine is better. Mood stabilizer, again, olanzapine, quetiapine. Right? Again, if you're on lithium, stop breastfeeding because it might cause toxicity symptoms in the kid. Okay, we are almost at the end of our class. Let's just discuss certain things, right? This is something which we do in our class, right? Time to check in and see how everyone's stress levels are. Open your cheat sheet, full screen cheat sheet. I will give it to you. I've already shared it in the group. I'll again share it to you. Okay, because if I put it in full screen, you're not able to read the thing because I've written a lot of things. I'll give it to you, Aaron. Yeah. Everybody log in. You can just open Mentimeter and type this code or use this QR code. Yeah, okay, Aaron. Menti.com. Type 665045 and type in how have your not shared. I will ask the Akalya to share it to all of you today. Okay, today I will make sure it gets shared. Raja. Very high, moderate. Okay, very low. Okay, that is interesting. Okay, Okay. Okay, thank you, Satyam. This exercise is just to let you know how your friends are also feeling. Even though a lot of people are having very high stress levels, a lot of people also have low and very low stress levels. See, so, it is it is an individual thing. It is not like those people are well prepared. It is not like those people are not prepared, etc. It is an individual thing. Some people with good preparation will have high stress, and some people with moderate preparation will have better stress. Some people with good preparation will not have stress at all. That also can be there. So it is an individual thing, and stress to our level is important to maintain a good exam preparation, also attending the exam, right? So if you do not have stress at all, you might not even go to the exam hall. It like you will be going at the last minute, creating some problems, etc. Where you have moderate stress or little thing that you can manage, then your mind will be sharp and you can do the exam well. So I wouldn't say stress at this time is bad, but try to control it from very high to a high or moderate level. Okay. So, see, if you are in the ideal zone, can you see the ideal zone? Then your performance will be better. So most of you are in the moderate stress, so that is the kind of the ideal zone, right? If you're having very low stress and very high stress, try to get it into this moderate zone. What can you do for that? One, you just create a schedule and stick to it. Prepare. Don't talk to your friends about how good or bad their performance levels are, right? Okay. Okay. Okay, and do not panic about the last minute some things that you can miss. Don't have the fear of missing out. You keep your basics strong, you will be able to answer any new questions. Okay, and if you're able to eliminate two options, if you're able to eliminate 50% of the options, definitely opt that question because you have a chance of getting it right. So don't be too cautious and leave all the questions in the fear of negative marks, but do attempt maximum number of questions. Okay. It's good to see that a lot of you all are in the optimal performance level of stretch. OCD is under thought possession, Srivadraj. Thought content is only delusion, nothing else. Right. So what can we do to help each other? What do you think can be done? We can say, I did not study, fears about others performing better than me. See, that you should never all have this kind of comparison. Obviously, your exam is a kind of comparison because they are giving percentile marks, but still, individually, you should not have a comparison of others performing better. You should have a comparison within yourself. You should perform the best of yours. So you should go into the exam hall and say that I should perform my best. My best, it could be 300 out of 300, it could be 250 out of 300, but it should be my best. You should not be like, what if the other person performs well? That kind of attitude will always bring in a lot of stress, which will, impair your performance. I must do it. I can do it. Good. So you can, have a neutral space. If you feel like talking to somebody, you can even call me. That is not a problem. You can, text me, reach out, and you can talk amongst each other, share 5 minutes of chit chat. See, this 5 minutes, 10 minutes of chit chat, you will feel like you're wasting your time, but this 5 to 10 minutes of relaxation with your friends or your family will improve your preparation for the next 1 or 2 hours. So have this little breaks. Good. I will win. Good. One last push. Yes, this is the last home stretch. Trust the process. Good, good, good. I'm happy to see all these words. So just one word that motivates all of you. Some people like Vidam Muyachi Vishwarupa Vetri. something like your movie dialogues. Some people like perseveration. Some people like, everything happens for a reason. Some people are like, no, I should do it. I must do it, which you all do. So one word that motivates you, dad. Okay, good. So you are doing it for your father. So that is motivating you. Or you are a father. Your child is motivating you. I do not know what it is, but still, it's good that it is motivating you. All is well. Good. Family. Good. Believe. Yes. Last 1 week is motivating you. Future. Good. So all of these things should be taken in a way that my emotional goal, parents. Okay. Yagam தான் உன்னை உயர்த்தும் பாத்துறையா? Okay. Okay, good. So we are at the end of the class only. If you want to leave, you can leave. I'm just having, because this is the last time I might be seeing you all before the exam. So I just want to Parama Padida. Okay. Trust. Future. One day or day one. Targeted. Good. Right. 3 year of college life. Okay. So, can you say like everybody is having some or the other way the same pattern? So for the person who said that others might perform better than me, everybody will have this fear. So it is better to have your own fear instead of I should perform well. Right. Good. So you are very close to the victory. Yes, Pa, please reach out to me through WhatsApp for personal talk. You are so close to the victory. Don't you dare give up now. This is just the last part. Right. Doing well in the exam requires 3 important things. One is going to the exam venue. Hope you have all booked tickets. Hope you have all made travel arrangements to go to the exam venue. Be on time, be ahead, because there is a lot of commotion of checking and all of those things which might cause a little distress to you. So be on time. Don't plan about going to the exam hall very late and attempt the maximum number of questions. So like I told you, if you're able to eliminate 2 options, give it a try, because your brain knows a lot of things. It has prepared itself for 1 year. It's been 1.5 years because of the postponement of NEET also. So your brain knows a lot of things. So if you make an educated, calculated guess, there is a high chance that you will get that answer right. So don't fear for that one negative mark and don't be too safe. Take a risk in attempting such questions. Okay. Right. Thank you. If you need any help, you can always feel free to chat.